Hello to everybody. Hello to the World Hearing Day 2025. We are happy to talk on this important day, which has the motto, Changing Mindsets, Empower Yourself to Make Ear and Hearing Care a Reality for All, to talk about a population which is disadvantaged. This is the population of people with intellectual disability. And we want to share with you this webinar, our great team who worked in such a project from Germany, University of Münster, but it is a presentation mainly by the ISA, International Society of Audiology, shared with the Union of European Phoniatricians, the International Association of Communication Sciences and Disorders, and it is registered at WHO, and also my university is proud on this webinar. Okay, we want to talk about undetected and untreated hearing loss in people with intellectual disabilities, which requires hearing screening, diagnosis, and intervention programs. So, why and how such a program is necessary? The prevalence worldwide of intellectual disability is about 1 to 3%. So it's a really relevant health and societal problem. Improved socioeconomic conditions, intensive neonatal care reduced the mortality of such people and made the prevalence rising. Causes of intellectual disability are genetic syndromes affecting the brain. The largest share of approximately 15% of intellectual disability is to be found in Down syndrome. Cerebral lesions, such as alcohol embryopathy, and unknown causes in 1/3 of the cases. According to the ICF concept of the WHO, this situation calls for an improvement of the body function, social participation, activity, and steered activity in particular, also for people with intellectual disability. We know that persons with intellectual disability are less healthy than non-disabled persons in cardiovascular, obesity, dental, visual, and musculoskeletal systems. Persons with intellectual disability have more often hearing loss than non-disabled people. Therefore, we are here. Hearing screenings in several thousands of athletes with intellectual disabilities in national and international Special Olympic Games were failed in 16 to 38%, with a median of 22%. And you see here the figure. It is overall the same: Indonesia, international, US, Germany. It's always the same figure. We performed reference tests in such screening situations and found that the screening specificity is 98%, sensitivity even 100%. So a screening reflects very well already the real hearing status of adults with intellectual disability. To compare the prevalence of hearing loss in the age comparable non-disabled population is about 4%. We checked it also with hearing screenings for children and adolescents with intellectual disabilities in special schools, and we found similar results. Hearing loss in persons with intellectual disability can be prevented or effectively treated by regular ear checks and hearing tests. by ear canal cleanings from cerumen, by early and consistent treatment of ear disease and hearing loss, for example, by hearing improving surgery such as grommets, tympanoplasty, hearing aids or implants, and continuous rehabilitation of hearing, communication, and speech-language skills. Hearing screening programs for people with intellectual disability are needed. This has been shown in the Special Olympics because the majority of cases with hearing loss detected there were unknown. Look at this figure. All the white bars, they were the cases of which were unknown. About 3/4 of the cases were unknown. And even in one of the games, we found 11 out of 14 cases with profound hearing loss or deafness who were unknown. So regular hearing screenings for people with intellectual disability were already recommended by the IFAS Working Group on Audiology and Intellectual Disability and in the Netherlands. However, follow-up diagnostics and treatment according to recommendation letters at the Special Olympics, for example, was poor. It took place in only 2 to 4% of cases. So we said maybe it's necessary to perform the screening programs in the living environment of people with intellectual disability. One predisposition was to assess which ear and audiometric tests are suitable for such outpatient hearing screening of people with intellectual disability. So in a population of 120 adults in a sheltered workshop, we checked a lot of audiometric methods and also tested the IQ of the people. And this is the height study, hearing evaluation for people with intellectual disabilities. And you see here in the N of the participants, we had 120 participants that for the single methods we used, we had only a few dropouts, the most for speech audiometry in noise. So it seems feasible. The lowest thresholds were revealed by pure tone audiometry, either the conventional one or the MAGIC, which is an adaptive test. You will see it later in a later presentation. So to summarize this, we said hearing loss in people with ID is highly prevalent and to a large extent unknown. The height study showed the feasibility of hearing tests in the living environment of the participants and determined the most reliable audiometric tests. So to ensure the participation in screenings, participants must be visited in their living environment. This was what we assumed. We transferred it into action and applied at the Fund of German's Federal Joint Committee a project grant for the project program for low threshold identification and treatment of hearing loss in persons with intellectual disability. In German, the abbreviation is Hörgeist. We got 1.7 million euro for it, and we want to establish with it the worldwide first national universal hearing screening and intervention program for persons with intellectual disability. Here's our wonderful team, shortly shown. And what are the aims of our project? To assess the feasibility and benefit of a large-scale program for identification, diagnostic, treatment, and treatment monitoring of hearing loss in people with intellectual disability in their living environment. We say go strategy. If this program results in a relevant reduction of or undertreated hearing loss in people with ID compared to the current situation of spontaneous show-ups, and if this reduction leads to higher quality of communication and life, it will become a new form of healthcare in Germany and hopefully also in other countries of the world. We wanted also to perform an economic cost-benefit analysis of this program. And we wanted to assess the age-dependent prevalence of hearing loss of people with ID and current situation of ear and hearing care. We also wanted to assess the hearing-relevant comorbidities, medications and risk factors of such a hearing loss, if we find one, and the hearing-related quality of life of people with intellectual disability. For this, we screened 1,053 people with intellectual disability in various facilities, 231 in sheltered workshops, homes for the disabled, sheltered homes, 405 children and adolescents between 7 and 18 years in special and mainstream schools and homes, and 417 children aged 1 to 6 years in special and mainstream inclusive nurseries and homes. If the screening was failed, diagnostics followed in the same facility after the screening, and if necessary, a therapy was initiated or recommended, or an already ongoing therapy was controlled in its outcome and optimized if necessary. We also invited a control group of 143 persons with intellectual disability via their families for the same procedure, but in a clinical setting, in departments of Phoniatrics and Pediatric audiology, which are responsible for caring for such persons, but also in ENT practices. We also made a health economic evaluation and modeling together with the health insurance companies. So here you see the program. The screenings, step 1 was otoscopy, screening TEORA, tympanometry, screening pure to audiometry, and if this was impossible, DP-gram or DPOA growth functions for threshold estimation. We also did a reference testing with extended PTA testing, and if the screening was failed, then you see here the methods of the diagnostics, including frequency-specific ABR, broadband ABR, or ASSR. And and if a treatment was needed, at first we reviewed an existing therapy. We did removal of the rumen where possible, and prescribed medical treatment, or something, balloons for tube ventilation. We initiated a fitting of hearing aids in this outpatient situation, and referred persons to ear surgery, including cochlear implants or implant diagnostics. It is published in B&J Open. So here you see such an audiometric testing in the living environment of persons with ID. Here a classroom, and this is Lucas, you will hear him later. And the equipment was a portable one, so we had a video otoscope, and you see we could, by teleaudiometry, have a look by a medical doctor into the ear of the participant. We had here a Pass Medical portable audiometer, which allowed everything, pure tone audiometry and variants, tympanometry, DPOE, TOE, ASSR, and ABR speech audiometry in quiet and noise. And here we have Philip. You will see him soon. He was the medical doctor of this project, who evaluated at a screen in the clinic in our department here the eardrum, but also the audiometric results, and gave recommendations for the further procedure. So for this, I thank you for your attention. And now I want to introduce Philip Martmann, who is the vice director of our clinic and was the doctor in this project. Thank you for this moment.
Thank you very much. I take over the screen now. I hope it works well now. Can everybody see the presentation? Great. Yeah, I'm very happy to present the first results, the outcome of a population-based study on the effectiveness and feasibility of regular hearing screening, diagnostics, and intervention program for people with intellectual disabilities in their living environment. My name is Philip Martmann. As Katrin already said, I'm the deputy director of the hospital, and I was the doctor who was like checking the results and deciding the diagnosis in most of the cases. And it was a very interesting program since, as Katrin said, this is the first attempt worldwide of a big national-wide screening, diagnostics, and hearing care program for people with intellectual disability. So in Germany, we are doing the first step of something that WHO recommended for quite some time already. So I'm very happy that we are all part of this progress here, and I can present the first results. So we screened 1,052 people with intellectual disability, and we came to the astonishing result that 42% of the cases were detected/diagnosed with a certain amount and kind of hearing loss. In only 5% of the cases, we could not detect if there is a hearing loss or not. So we stayed with the unclear hearing status, which is an amazing result. We expected a lot more of cases being unclear, since we are working there with people with trisomy, we are working with people with autism spectrum disorders and other things like that that make diagnostics in some cases very challenging. This is a very good start for the result, but were also surprised that we detected 42% of cases. So 42% of the people had a hearing loss, which is quite a lot compared to other studies, like things that we saw at Special Olympics, and I will come to that point a little later. So here we go a bit more into the details of the hearing results. We see here that we split up into 3 different age groups. So they are called group K, J, and E, which is coming from the German Kinder, Jugendliche, and Erwachsene, which means children, adolescents, and grown-ups. What we see here is that by the age going up, we see the hearing loss going up, but a lot faster than we see it in the general population. We see that the people above 18, but also like to the older age that we had in some care homes, we see 66% of the people have a hearing impairment, which is quite a lot. On the other hand, we see that with the children, with the 7% of unclear hearing ability, we have the higher percentage there, because of course, children are always a bit more difficult to detect their hearing status, but also children with mental disabilities are even more challenging. So we see that we have there 7%, where in the adults we have 1%. So we also see an aging effect that results in a better compliance of the people in the tests. What we see here is the same split up by age, but we see it a bit differently by decades. And here we can see it a bit more finer granulated. that we have really with the age 0 to 6, we have 27%, and then it goes continuously up almost. We have a little bit of a balance here between 6 and 30 years, around 30%, but then it goes up very quickly. So we see that people with intellectual disabilities have a quicker aging process of the hearing ability than we have it in the general population. So we have a much higher rate and also higher severity of hearing losses in these people than we see in the general non-mentally disabled population. What we see on the next slide here is the hearing impairment by institutions. We split up by special nursery, daycare centers, special schools, regular schools with people who get supported there, all sheltered workshops and other things. And we see that the grade of disability also reflects in the grade of hearing loss. And this is what I said before, where we were a bit surprised that we have such a high rate of hearing loss of 42% overall in our population, which is due to the fact that other studies usually were things like Special Olympics, where people could take place in games and stick to rules, do sports, can run and things like that, where people who are basically in bed and can do barely anything are not represented in those studies and evaluations that were done with the Special Olympic Games. So therefore, we have a much broader spectrum of people here, from kind of high functioning people to very low functioning or capable people in the everyday life situation, which reflects then in an averagely higher prevalence of hearing losses in our study population compared to others. This is the explanation. We can see here that we see that most cases of the hearing loss are in homes for people with intellectual disability, where we see 80% of the people who are very majorly disabled, that they cannot follow a work, they cannot go to school, they cannot be anywhere. They are just like living in their home, they're taken care of, they have their life there. Those people who are majorly disabled have a much higher grade or a risk of having hearing loss, which is 80%, compared to special schools, for example, where we only found 31%. On this slide, we see the hearing impairment by severity, which is basically what we expected in a way. Of course, that we have the normal hearing with 56% of the cases, the unclear hearing status that I mentioned before with 5% of the cases. And then we have the going up from mild, moderate to profound hearing loss and then to deafness, going up bit by bit, which makes sense because, of course, the milder the hearing loss, the more likely it is to appear. We don't start with deafness, we start with a mild hearing loss, which then over time grows possibly into a profound hearing loss or even a deafness. So we see a consistency of our results in this kind of falling down scale of hearing losses with the severity. We also differentiated by the type of hearing loss. So we have the conductive hearing loss, which is basically could be a blockage by cerumen of the ear canal or of the middle ear, a problem, for example, a glue ear, or other problems with the building of the little bones in the ossicles of the middle ear. And then, of course, the sensory neural hearing loss, which is an inner ear problem with the hair cells or even with the nerve behind the cochlea, and then the mixed hearing losses, which is a combination, or combined hearing losses, which is a combination of the first two. And we see here that the rate of sensory neural hearing losses is very high. We see that an overall rate of people where we have to do something, so the combination of hearing loss and unclear hearing, is at 44%. So that's the cases where we have to do something, either because we have a clear diagnosis, which means that we need to apply a treatment such as hearing aids or clearing of earwax or something like that, or with unclear hearing, we have to do something as well because we need to know what the hearing ability is. So there we need to do further diagnostics, either within our program or even external diagnostics if people are so unable to comply for the tests, that we say we have to put them into a narcosis to do hearing tests, objective hearing tests while they are sleeping. We then looked at the quality of our screening, which was, of course, also something very important for us. So if we compared the, oh, I'm sorry for a little spelling mistake here, the screening to the hearing loss in T1, where we compared basically our screening quality to the gold standard quality. And we saw that only very little cases were false positive or false negative. So we have here down here, this is the most interesting part, a specificity and a sensitivity that is above 96%, which is incredibly high. And we have also a very narrow confidential interval, which is above 95%, which is a very, very good result if we look how difficult the population is we are looking at in terms of diagnostics. We can compare it to the newborn hearing screening, which is a much easier test that takes only a few seconds in children that are, as newborns, a lot of the time sleeping and therefore quite compliant. So, and we have almost the same height of result quality in our people here, even though the spectrum of different diagnostic tools that we are using and the compliance of the people is much more challenging than we see it in the newborn hearing screening, which is a proof that this is a program that actually works, and we can actually find out by a very high quality the result of the hearing ability of those people. We also see some differences over time, since we did the diagnostics at T0 and T1, which means the first screening or the first diagnostics, and then 1 year later, the repeating of this same testings, where we see that about 7% of the people improved over 1 year, which is due to temporary hearing losses such as tympanic effusions that were resolved, or earwax that was cleared, or uncertain diagnostics that could be resolved over time. So we see a certain improvement in 7% of the cases. On the other hand, we see 6.5% worsened with the hearing loss over the year, which can be due to borderline decisions at T0, or that we decide, for example, that we decided based on very few otoacoustic emissions that we got, or that we see a progressive hearing impairment or a new tympanic effusion. What resulted then was, of course, that we tried to help them with giving them referrals for further diagnostics or referrals to further treatment, or we gave them hearing losses, or we prescribed them eardrops and other medication like that. And you can see here very nicely in how many cases. So 9% got hearing aids, 27% got referrals to further diagnostics and other things, and 5% got both. In 59% of the cases, we didn't do anything and said it's so mild that we are just going to check again 1 year later, for example, or advised after the second screening that we advise further continuation of checkups in yearly or 2-year gaps. And here we can see those 14% of the cases which are put together by the 9 plus 5% who needed further diagnostic and care. And then 338 people, which is 32%, needed further diagnostics. And 3% of the people needed, for example, anti-inflammatory or antibiotic medication due to middle ear, acute middle ear infections or ear canal infections. And even 10 people had such high hearing loss that we recommended further preliminary diagnostics for a cochlear implant treatment, which would then be an MRI, for example, a CT scan, confirmation diagnostics, and things like that, before we can decide for a cochlear implant. So what happened with those prescriptions? How were they received or used? Here is a bit of a, well, we can say a bit of a shocking result. As much as we see that our screening and our diagnostic program leads to very stable and very reliable results, we also see that the prescriptions and the recommendations we did were very often not used and not carried out or taken, basically turned into reality. Only 61% of the recommendations were followed, and with the prescriptions, almost 40%, 39% of the prescriptions were not used. This had a lot of different reasons. Usually the reasons were the caregivers, we must say that, because we spoke to them and said like, okay, why hasn't this or that recommendation happened within the last year since we saw you the first time? And they said, well, we didn't see the necessity, for example, or we said and heard the person doesn't need it. He has always been like that and he's fine. He refuses to wear his hearing aid. The participant would lose the hearing aid, so therefore it doesn't make sense to give him something. And in very many cases, it is just a lack of knowledge of the caregiving people that lead to this problem. And this is even higher than with the prescription. In the hearing aids, 76% of the people did not get their hearing aids as we prescribed them. And looking at the fact that we have a very strong sensitivity and specificity in our screening and diagnostics, which means that our results are true, it is quite shocking that the people didn't get the help that we identified for them after 1 year due to these excuses that we see in this population and by the caregiving people. So there's a lot of restriction in the staff in terms of time and staff, and all these things lead combined to the conclusion that there is a big lack of information and understanding of professional caregivers and relatives and people who take care of those people with intellectual disability, which leads to a negative attitude towards the intervention and the help basically that those people needed. So I come to the end of my part and give back to Katrin, and thank you very much for your attention.
Yeah, thank you so much, Philip. This is really important results. And now we go on with Ava Nagipur. Ava is also a medical doctor, but she's also one of the 4 doctoral students we have in our program. And we are looking forward to your presentation now, Ava.
Thank you very much, Katrin. Thank you very much, everyone. I'm trying to find the way to present. 1 second. Hello, and thank you. Very happy to be here, and I will share our preliminary results about hearing loss-associated diseases in people with intellectual disabilities today. First, to the background, we know from existing literature that there is an increased proportion of additional diseases with earlier onset of disease and a higher mortality rate in people with intellectual disability compared to the general population. Heslop et al. Also showed that compared to the general population, twice as many deaths in people with intellectual disability were due to causes that could have been prevented by appropriate health care. And Baxter et al. Described an increased risk of unrecognized diseases. They found in their study previously unknown diseases in 51% of the cases in their health check. 63% had 1, 25% had 2, and 12% had more than 2 previously unknown diseases. And as we've already heard and as established, hearing disorders represent a specific health challenge for people with intellectual disability. The decisive factor here is an increased prevalence of hearing disorders in people with intellectual disabilities and a systematic gap in diagnostics and care. So in summary, we can conclude that first, an increased proportion of additional diseases in people with ID is present, and second, a specific relevance of hearing disorders prevails within this population. So as part of the study, the following questions are relevant and can be derived from this. First of all, which medical conditions occur most frequently in people with intellectual disabilities and hearing loss? Second, is there an increased quantity of diseases compared to people with ID without hearing loss? And third, to what extent does the presence of hearing loss, degree of hearing loss, and degree of intellectual disability quantitatively influence the number of diseases, medical intake, or surgical interventions? We did pay particular attention to sex and age when answering these questions. As we've already heard, as an overview, we had a total of 1,053 participants included in the study and in the data analysis, of which 37% were female and 63% were male. 1 person was intersex. The mean age was 24 years, and the age range, which is quite special, was ranged from 1 to 90 years. Using an algorithm, we distinguished a temporary from permanent and progressive hearing loss and defined the group of manifest hearing loss for the analysis of concomitant diseases. And as Philipp Martmann already went into detail, the hearing examination showed that the presence of hearing loss increased over the course of life, as you can see in the upper image. And those with manifest hearing loss were distributed as you can see in the lower picture across the levels of intellectual disabilities, and 44% moderate intellectual disability, 31% severe, and 18% mild. Overall, the hearing examination revealed 40% with and 52% without manifest hearing loss. The diseases recorded that we recorded via questionnaire were systematized and coded according to the current international classification of diseases in the 11th revision, the ICD-11. And here we see an overview of the most common diseases, more than 5% in the cohort with hearing loss. In the upper row, you can see the disease supercategories, and below there are the more specific disease entities. As you can see in the first column, endocrine, nutritional, and metabolic diseases were the most common category with 35.7%, followed in decreasing or descending order by developmental anomalies, diseases of the circulatory system, diseases of the nervous system, psychological, behavioral, and neurodevelopmental disorders, diseases of the visual system, diseases of the muscle and connective tissue. Symptoms, signs, or clinical findings not elsewhere classified, which includes auditory hallucinations, tinnitus, and similar specific diseases, diseases of the ear or mastoid process, and last but not least, factors influencing the state of health or leading to healthcare utilization, which means ear, visual diseases, and the medical history. If we look closely, the top 10 most common diseases or disease entities were hypertension, followed by obesity, by Down syndrome, third place, epilepsy, visual impairment, diseases of the muscle, anomalies of the skeleton, mental, behavioral, or neurodevelopmental disorders, conditions of the spine, and nutritional disorders. Overall, the most common conditions occurred in higher percentages in participants with hearing loss compared to those without hearing loss, with 8 of these conditions that you can see in orange being statistically significant in terms of odds ratio and 95% confidence interval, with hypertension, obesity, and Down syndrome being the most commonly observed in patients with hearing loss compared to those without, followed by visual impairment, mental, behavioral, and neurodevelopmental disorders, spinal disorders, diabetes, and hypothyroidism. When comparing the quantity of medication intake, we see that the main value with hearing loss was 2.5 compared to 0.85 without hearing loss. And regarding number of diseases, we see that the mean value with hearing loss was 2.75 compared to 1.66 without. So overall, we can conclude that the most common diseases occurred in a higher proportion of participants with intellectual disability and hearing loss compared to those without. And people with hearing loss showed an increased use of medication and a higher number of diseases compared to those without. This suggests that, as you can see in the lower 3 points, that the increased proportion of additional diseases in people with intellectual disability and hearing loss does require targeted attention, that every newly diagnosed disease should be seen as an indicator for further diagnostics in terms of prevention, in terms of early detection, that this prevention and early detection and treatment, that this is crucial in order to avoid complications, to improve quality of life in the long term, and that interdisciplinary care is essential to ensure the best possible multidisciplinary and patient-centered care. Thank you so much from my part.
Thank you, Ava, for those highly interesting results and for sharing them with us. Our next speaker will be Lukas Prein. Lukas is Master of Science in Audiology, and he is also what we have in Germany, hearing aid acoustician, a person who fits people with hearing aids, and he was the person who did the most of the screenings and diagnostic testings of hundreds and hundreds of participants. I forgot to mention that we assessed all those 1,053 persons twice. After 1 year, we assessed them again to check what came out, which treatment they got, and how their hearing developed over time. Okay, Lukas, the stage is yours.
Yeah, thank you, Katrin, for the nice introduction. I hope you can see my screen.
Yes, we can.
Okay, perfect. Okay, yeah, I present the topic people with intellectual disability, hearing screening, and diagnostic methods. First, I will give you a little overview over the methods and for determining the hearing ability. Depending on the disability level, compliance, and test performance, the hearing threshold for people with intellectual disabilities can be determined using different subjective and audiological tests. In the HERGAS study, we use the subjective tests with active participation, like tone audiometry and speech audiometry, also the objective tests with no active participation, like otoacoustic emissions, tympanometry, and auditory evoked potentials. The hearing ability in this population leads to an inaccurate results due to certain risks. For example, there is an understanding the task, concentration, or other motor skills, and there is the initial training necessary to get precise results and focusing on basic hearing process. A clear and simple language is helpful, and in addition, people with intellectual disabilities place special demands on the audiologists and require special skills. For example, considered approach before each person, flexibility in carrying out the tests, speed, training, and more. And the most important thing at this point, determining the hearing ability in people with intellectual disability is possible. And the following slides, I will present and illustrate how this was achieved and how I worked, or my colleagues and me worked. So we start with acute tone audiometry and variance. First, Katrin said a few minutes before, we used the Sentiro Advanced and handheld audiometer, and we use condition play audiometry, all the conventional pure tone audiometry. You can see it at the right top, or the multiple choice graphic interactive check, the MAGIC test, there is a little pad. You press on the pad and you can hear something or not, and the participant can push the touch screen. And the other way is we need at the and there you can see two pictures with how the Putron audiometry was done. And the approach is chosen based on the individual's disability, compliance, and test performance to ensure accurate results. And the Putron audiometry and variance was successful in the hearing in this project, in the HERGAS project, in 63% of the participants at T0, and 1 year later at T1, the Putron audiometry and variance was successful in 74%. There is an increase of 11% for this audiometry, and this clearly indicates that a training and education effect occurred for both the individuals, also the audiologists. We used also the otoacoustic emissions. This is a helpful tool for the diagnosing hearing problems in people with intellectual disability. And this is a non-invasive test and is quick and easy to perform. OREs measure the sounds emitted by the outer hair cells in the inner ear and giving us an overview into how well it's working, especially the outer ear cells. And we have two different test variants. The transient evoked otoacoustic emissions, the TEORE. There is no precise threshold determination, but it supports it, and also there's a limited and frequency-specific information range. You can this at the right picture. And then we have the distortion product otoacoustic emissions. They are frequency-specific using the dPgram and are not precise threshold determination, but they also supports it. If you want to get a precise threshold determination, you can use the DPORE growth function, and this success from the whole ORE, the results from the study. At T0 we have 89% and at T1 92%. The next slide is the tympanometry. The tympanometry is a quick and non-invasive test that measures the middle ear's functional state, and it takes only a few seconds to complete and doesn't require any invasive problems. So the results, you can see it at the right picture. There are three curves: a normal peak, this is a black one, a left peak curve indicating an under pressure, this is a red one, and a flat curve, this is a blue one, indicating fluid in the middle ear. And the results in the HERGAS study from the tympanometry success at T0, there are 92%, at T1, 84%. And the results here show that in over 1,000 cases, we have a normal pressure, a normal functional tympanometry. At the next slide, I will present you the speech audiometry with variance methods, and depending on the person's ability and age. Tests like the Freiburg speech test, you can see it at the right top, or the MATCH, the Münster audiometric test for children, are in Germany common hearing tests, speech tests, but we can measure this one in noise and in quiet. But sometimes these tests are impossible, like when someone can't speak or has trouble speaking clearly, or if someone doesn't know much German of the German language, and also higher cognitive load, in particular in noise. At this slide, I will present you the auditory evoked potentials with the broadband brainstem evoked response audiometry and the frequency-specific auditory steady state response, the ASSR. You can see this at the right picture, and the brainstem evoked response audiometry at the bottom. Acoustic stimulation triggers a response in the brain, which can be measured using special electrodes on the scalp. To get accurate results, a quiet and comfortable environment is needed. The person should be relaxed or asleep, and in schools, in the Hörgeist study, I always try to, that's a child fall into sleep in a school with sleeping or in a bedroom, and the person also should be relaxed, and the electrodes placed here at the skin. During the test, the equipment should be monitored and adjusted as needed. Guy Lightfoot say a sleeping child is a ticking time bomb. That means work quickly but carefully. And there is also, I said at the beginning from my presentation, speed is a very impossible factor for the auditory measurements by people with intellectual disability. I come to my summary and conclusion. Hearing tests for people with intellectual disabilities needed to be done carefully, and a portfolio of audiometric tests must be available. Trained experts or audiologists should use a variety of methods to get accurate results, and they should also consider the person's needs and use a simple language they can understand. A combination of pure tone audiometry and DPORE growth function can be a useful screening tool, and the hearing ability of most people with intellectual disability can reliably be assessed in an outreach setting, as also shown in this Hörgeist study. And I thank you for your attention. I close my slides. Yeah.
Thank you very much, dear Lukas, for this nice presentation. And now we step over to Niels Vogt. Niels is a hearing aid acoustician, and he was the one who who fitted the persons we detected, or part of the persons with hearing aids in their living environment, which is a certain challenge. And Niels will now talk about this.
Thank you very much. Hello and welcome. My name is Niels Vogt. I'm the Managing Director of Kampmann Hörsystem in Bochum. I'm a master hearing aid and specialist, and have supported this project from the beginning. At first, I thought our main task was to fit hearing aids. But the biggest challenge was explaining to users and their families what hearing loss means and how it affects their lives. We visit people at home or at work to fit their hearing aids on site. The first question was, can fitting hearing aids at home or work be just as good as fitting them in a store? What do we need to make it work? What are the benefits? Are there any problems with fitting hearing aids in a store? Normally, hearing aids are fitted in a store. In the store, the restroom must be quiet, less than 40 decibels to get a perfect hearing measurement. However, stores often feel medical and sterile. Some people find it hard to drive to the store or don't have time for appointments. Also, there are not many family members around to offer support. At home, the situation is different. People are in a comfortable and quiet place. They don't have to drive anywhere, and family members are there to help. The hearing aids can also be tested in real-life situations like watching television. We also visit people at work. If their workplace was noisy, we used a quiet room nearby. Being in a familiar place helped people feel comfortable. Their colleagues could also hear the difference with the wear hearing aids. To summarize, fitting hearing aids at home or work was just as good as in the store and even had extra benefits. The hardest part was explaining hearing loss to the users and their families. Many people don't understand the effects of untreated hearing loss. During our first visit, we explained the different hearing aids and how they are fitted. We took ear impressions to make custom molds for a perfect fit. People could also choose different colors of hearing aids. After about 2 weeks, we fitted the hearing aids. Since most people had hearing loss for many years, we started with lower amplification to help them adjust. Over time, we slowly increased the amplification to the correct level. After a few weeks, we did a final test to check the results. We measured how much their hearing improved and did a speech test. We also checked if they were wearing the hearing aids regularly. The biggest challenge was making people understand with hearing aids are important, not just for them, but also for their family and caregivers. That's why it was so important to include the environments. They play a key role in making sure the hearing aids are worn regularly. The third challenge was adaptation and training. People must wear the hearing aids every day. If don't, their brain won't get used to the sound and the hearing aids won't work well. Since most people have hearing loss for a long time, we couldn't give full amplification at the beginning. Instead, we started at 80% and increased the level automatically over the next weeks. But this only worked if the hearing aids were worn regularly. If people didn't wear them enough, the amplification didn't increase correctly. Because of this, some hearing aids were not fully adjusted at follow-up appointments. To improve this, we had to involve family members more to make sure the hearing aids we used daily. When caregivers helped, we saw much better results. We measured good improvement with hearing aids compared to without. However, in quiet speech, the results were not always perfect. After more time, the results would have been better. For a normal and a loud speech, the results were very good. We saw a clear improvement. Thank you very much.
Thank you so much, Niels, for these interesting results you presented. And now it's my pleasure to announce Professor Caroline Schäfer, who is logopedist and speech-language pathologist, but also specialized in hearing pedagogy and rehabilitation. Please, Caroline, the stage is yours.
Thank you so much. I think that Niels has to stop sharing his screen first. Okay, thanks. Okay, let me start. Thank you for your kind introduction, Katrin. My name is Caroline Schäfer. I work as a professor at the Institute of Special Education with a focus on people who are deaf or hard of hearing at the University of Duisburg-Essen right now, and I will present the results of our sub-project of hearing rehabilitation and support for people with intellectual disability after hearing aid provision from Hörgeist. A total of 6 people took part in our sub-project Hörbegeistert. These people had previously participated in the Hörgeist program, which we heard about before, and they either received their first hearing aids or new hearing aids because the old ones were not suitable. And the 6 people, they were between 59 and 83 years old, with a mean age of 67 years for men and 2 women. 4 people were already retired at the time of the program, and 2 people worked in a sheltered workshop. The hearing losses varied from mild to severe, and all these individuals were fitted with hearing aids on both ears. Wearing time of the hearing aids was more than 8 hours a day for all individuals. So for our hearing rehabilitation program, we mainly had people who already had a high level of acceptance, and therefore they were certainly very interested in taking part in our program. And when we evaluate these results later, we will have to take this into account as a selection bias. To determine the needs of people with intellectual disability before implementing the program, we conducted surveys using questionnaires and interviews with the people with intellectual disability, and after that also with their caregivers. And for us, it was very important to develop the program in a participatory way. In the interviews with people with intellectual disability, we used proven methods such as talking mats, and when necessary, asked our questions in plain language, and also visualized our question with pictograms. All of the people were able to answer our interview questions and give examples from their daily lives. And this figure, which you see right here, shows examples of questions on the use of the hearing aids, to what extent various actions can be performed independently or require support according to the impressions of the caregivers. On the basis of these answers, it quickly became clear to us that a hearing rehabilitation program should not only focus on people with intellectual disability themselves, but necessarily has to be a systemic approach. If we had only focused on people with intellectual disability in our support, or limited the hearing rehabilitation program to hearing exercises, we would have to run the risk of confusion about responsibilities, or of nobody knowing how to clean the hearing aids, as you see in this picture. I will now show you some examples of the content of the hearing rehabilitation program. Here you can see on this slide the opening ritual of each session, during which the functionality of the hearing aids was checked. This is a step-by-step guide to fitting the hearing aids to the ears. The procedure shown here is practiced with the people with intellectual disability by themselves, and also included in the care and support plan of the institution where they live. And in this way, the caregivers are automatically integrated into the handling process of the hearing aids. Here you can see a checklist for cleaning the hearing aids. And overall, the handling of the hearing aids takes up a great deal of space in our hearing rehabilitation program, as this is where the greatest needs were identified in our interviews and questionnaires. After the assessment of needs by interviews and questionnaires for a hearing rehabilitation program, when we completed this and a pilot project was carried out with our 6 participants, we had 4 areas identified that are important for a hearing rehabilitation program. It's information on hearing loss, not only for people themselves, but for everyone. Information on hearing aids, also for everyone. Handling of hearing aids for everyone. And communication tactics, which also play a role not only for the individuals themselves, but for the entire environment. So they must be taken into account by everyone involved in hearing aid use. We are excited to see how the program will continue to develop, and I thank you very much for your attention.
Thank you so much, Caroline. It is such an important part of this program, because we have seen we are good in screening, we are good in diagnostics, show this further, but we are not yet good in intervention. And this is the most important step, to have a hearing rehabilitation for those people. Thank you.
Thank you.
Now it's time for Susanna Zilunkowski. Susanna is a medical student and also one of our doctoral students, and she had a challenging task to find out something about the hearing-related quality of life of people with intellectual disability and how we can improve it.
Yeah, thank you very much. I will share the slides. Yeah, as Catherine has said, I would like to share our results about the hearing-related quality of life. But before I will do that, I want to show you our results about another topic, because we also examined how people with intellectual disability and also their caregivers evaluated their hearing status. As you have already heard in the beginning, previous studies have shown that hearing loss is often not recognized and or diagnosed in people with intellectual disability. One reason for this could be that the self-assessment of the hearing ability is more challenging for these people. Our aim was, therefore, as I said, to investigate how reliable people with intellectual disability, but also their caregivers, can estimate the hearing ability of the people with intellectual disability to seek the necessary medical help. Therefore, we asked both the participants in the screening, but also their caregivers during a questionnaire, for example, their parents or legal guardians, to evaluate the hearing status of the participants in the beginning of the study. These results were summarized to the binary variable hearing status evaluation, in which we differentiated between normal hearing and suspected hearing loss. We compared these results of the evaluation with the audiometric measurements to examine to what extent the results were consistent. Overall, 59% of the participants correctly evaluated their hearing status, as did 61.5% of their caregivers. In contrast, the hearing status was evaluated as normal in approximately 34% in both groups, in cases where we diagnosed a hearing loss. In these cases, the hearing capability was overestimated, and these people would therefore not seek the necessary help. Contrary to this, both groups evaluated only in approximately 6% the hearing status as suspected hearing loss in participants with normal hearing measured. To summarize, it can therefore be said that due to the low reliability of the evaluation of the hearing status, regular audiometric tests are recommended for all people with intellectual disability in order to detect and treat hearing loss at an early stage and according to the applying from the WIO. Now to the hearing-related quality of life. We wanted to investigate whether hearing loss affects the hearing-related quality of life in people with intellectual disability. Studies in the general population have shown that hearing loss often impairs the quality of life, but until now, no studies have been carried out on this topic specifically for people with intellectual disability. To investigate this question, we first developed 9 features based on the scientific literature to determine the hearing-related quality of life. These features were then answered by the caregivers of the participants at the beginning of the study. Based on these features, we calculated the hearing-related quality of life score, which could range from 1 to 4 points, with 1 being poor and 4 being good hearing-related quality of life. After that, we carried out a multivariable regression to examine a possible association between the hearing-related quality of life score and the degree of hearing loss we measured based on the current WHO classification. Altogether, the mean hearing-related quality of life score amounted to 3.0 points of 4 possible points, and it is apparent that the average hearing-related quality of life score declined slightly with the increasing degree of hearing loss, as you can see in the graphic. Now you can see it. The multivariable regression revealed a small but significant association between the score and the degree of hearing loss. However, only a small part of the variance in the score could be explained by our regression model. Overall, we can therefore summarize that the degree of hearing loss has a small but significant negative influence on the hearing-related quality of life, although further studies are needed to explore this in more detail. Thank you very much for your attention.
Yes, and thank you very much, Susanna, for these amazing results. We were not sure whether we can measure really reliably the quality of hearing-related quality of life of our participants, but we are happy that we, in the end, could it. Now, another doctoral student who's also already a medical doctor, Anna Wiegand, will tell us something about what happens if the diagnostics cannot be done in the program directly, but has to be carried out in an external institution. Does it happen, and when and how? Please, Anna.
Hello, and thank you for your introduction, Katrin. I'll share my presentation. So I hope you are able to see the presentation. Okay, perfect. Yes, I will talk today about hearing assessment in a clinical setting for people with intellectual disability as part of the HERGEI study. And now I have to see how I go further. Sorry, yes, no. Here you can see the study design of the HERGEI study as explained by the previous speakers. In this presentation, we will focus on the period between T0 and T1, especially on the diagnostics part, clinical diagnostics and/or therapy. And we will examine the results for the outreach group. Our timeline for the study was as follows. At T0, the initial screening took place, and if the screening showed any pathologies, further diagnostics, and if necessary, initiation of therapy were carried out immediately on site. In cases where on-site diagnostics were not possible or incomplete, or if the results were inconclusive or monitoring was required, participants or their caregivers, like parents or legal guardians, received a medical report after that with referrals for further external diagnostics. And between T0 and T1, we conducted telephone interviews to check whether the diagnostics had already been completed and whether reports and results were available. If diagnostics had not yet been carried out, the reasons were recorded, and the participants were reminded to follow up the referrals. At T1, approximately 12 months after T0, the second screening was conducted. And if data collection had not been successful beforehand, the information regarding external diagnostics were completed. If new or previously known but untreated conditions were found, further external referrals were made, like Philip said before. After T0, you see the total of 262 participants among the initial 1,053 received referrals for external diagnostics. Due to this and other reasons, there were 19 dropouts, leaving a sample size of 243 people with referrals. Out of the 243, 241 received referrals to otorhinolaryngology or phoniatrics and pediatric audiology, and 5 received referrals to imaging, resulting in a total of 246 referrals. And you see the bullet points show the types of diagnostics that were requested, such as tympanometry or thin layer CAT scan of the petrous bone. Let's now look at the results. Out of the 246 referrals, 93 were followed up and diagnostics were completed. We received 22 reports from these cases, and however, for 153 referrals, the diagnostics were not completed. The reasons for not following up on the referrals were recorded beforehand in predefined categories. As you can see, the main reasons were not pursued an appointment, refusal by caregivers, and refusal by participants. And we will now take a closer look at two of these categories. The reasons given by caregivers for declining further diagnostics were, on the one hand, that they did not perceive a need for them, and on the other hand, other severe health conditions of the participants were prioritized, and additionally, a lack of staff capacity was cited as a reason. Under other reasons, or unknown, yes, it explains, it became clear that in some medical visits, only therapy was provided without any diagnostics, or that the diagnostics were planned to take place at a later date after the telephone data evaluation. Let's move on to the findings. Overall, 38% of the initiated external diagnostics were completed, and we said before, the main reasons for unsuccessfully completion were not pursued an appointment, refusal by caregivers, and refusal by participants. And it appears that there is often a lack of understanding of the symptoms, issues, and consequences of potentially undetected hearing impairment. And another key factor is that the initiation of therapy often takes precedence over diagnostics. Therefore, an important takeaway is that there's a clear need for education and training about hearing impairments, both for people with intellectual disability and for their caregivers, but maybe also on the side of the professionals. This concludes my presentation, and I thank you for your attention.
Thank you very much, Anna. Great. And another Anna is now following, Anna Sophia Schwan, who is also a medical doctor and a doctoral student in this project. Please, Anna Sophia.
Thank you very much, Katrin. Trying to share my presentation. Okay, I'm going to, do you see my presentation? Yeah. Okay, I'm going to speak about people with intellectual disabilities and the hearing intervention after the Hörgeist study. We are once again between T0 and T1, as the previous Anna told you beforehand, and we recommended treatment in some of the participants. The treatment recommendation were hearing aids and other treatments as cerumen dissolving therapy, improvement of tube ventilation, and drug therapies, as well as hearing improving operations, for example, paracentesis or the insertion of tympanostomy tubes and hearing implants. In 283 cases, we recommended a therapy that's around 27% of participants. We prescribed hearing aids in 156 cases and gave out referrals for treatment in 152 cases. In 25 participants, we gave out a prescription as well as a referral. Of the 156 prescriptions for hearing aids, we had 38 participants who received hearing aids. That's around 24% of those participants, and in addition, 9 participants received hearing aids who got a referral for further diagnostics and treatments. And the most important reasons why hearing aids were not fitted were rejection by participants and rejection by the carers, as well as carers who did not make an appointment, and in some cases the local ENT doctor rejected a hearing aid. We issued 152 referrals for further treatment. 18 participants told us that they showed themselves and there was no further treatment necessary. 55 participants did not present for their further treatment, and in 62 participants, the treatment was provided. That's around 41% of those. And in the most cases, there was a cleaning of the ear canal done. Then there was some insertions of tympanostomy tubes. Hearing aids were fitted, as well as ear balloon therapy conducted. As Anna told us beforehand, there was some referrals for further diagnostics done, and of those further treatments were resulted. There was some insertions of tympanostomy tubes, further cleaning of ear canals, as well as the hearing aids fitted, as I told you beforehand. So we can conclude that 35% of the recommended therapies were implemented, and the most important reasons why those were not realized was a rejection by carers, including the unwillingness to seek an appointment and or the rejection by the participants. And that was most often the case because of a lack of understanding for the need of a diagnostic and treatment in those people. So I would conclude that there's more need for information and training for both people with disabilities and above all their carers. Thank you very much.
Thank you, Anna-Sophie, for the interesting results and also a little bit depressing results. And now I, for the last time, share my screen to say some concluding words. What are the needs? What is our call for action in this program? We have seen, we have a high proportion of 44% of persons with intellectual disability who has a hearing loss. They are most often adults who live in homes. You might have noticed that the numbers are a little bit swaying. It depends on whether we should look on the first or on the second screening and so on, permanent hearing loss. But it's something between 42 and 44% which have a clear diagnosis. This is not a screening result. This is diagnostic result. Also, the hearing of people with intellectual disability ages faster than in the non-disabled population. The hearing loss is predominantly unknown and inadequately treated. We did not show you the results of the already present hearing aids or hearing loss treatment, which was also in the most cases insufficient because for a long time not checked, and it takes every day efforts of people, of caregivers to let the hearing intervention function. So as you have seen before, batteries of hearing aids, putting the hearing aids in place, explaining why it is done, and so on. So we could show that the implementation of a program of regular hearing assessment in intervention and long-term monitoring seems useful and necessary to reduce untreated or inadequately treated hearing loss. It can improve the hearing-related quality of life and enhance communicative abilities, social participation, and independence of this underprivileged population. However, two components are critical to the success of such a program. The first is a comprehensive education of professionals, caregivers, family members, and the society as a whole about the hearing situation of persons with intellectual disability and the benefits of hearing screenings and ear and hearing care is absolutely necessary. It's like in former times with the newborn hearing screening. We needed to educate professional parents and the society as a whole, and now we should do it for the people with intellectual disability. Furthermore, a structured communication and hearing rehabilitation and training of those diagnosed with a hearing loss and of their caregivers is absolutely necessary. If we get this done and we make now the next step before implementing such a program to set those 2 points into function, and then we could recommend and start with universal hearing screening, diagnostics, and intervention programs for those people. I hope this all was interesting for you, and we all together wish you a good World Hearing Day 2025. Goodbye.